Okay, good afternoon, everybody. I think that we are now online, ready to transmit from Toulouse with Dr. Khimene. Did you hear me, Jean, and the audience?
Yeah, we can hear you and see you well. No problem.
Well, so I have the great opportunity and chance to work this afternoon with Dr. Khimene and after with Professor Saito. It's really for me a great challenge. And we will first, I think that you should introduce the first patient, Jean, and then go back to the live, or did you already show the case of the patient?
No, thank you, Ferdinand, for coming. Thank you for Shigeru also for coming in Toulouse. And again, I will express all my thanks from the board of EuroPCR for your presence here in our cath lab in Toulouse. So the first patient is a male, 68 years old, insulin diabetic patient. I have the slides. You can have the slides? No, it's not possible. So it has a silent, so it's diabetic patient. Clinical history is the following: silent ischemia, absolutely no pain, but a positive stress test at 90 watts, and angiography showed a normal left ventricular function with LVEF was close 75%. There was some disease on the left, ostial left main stenosis, but angiographically it was not critical. There was a long disease, calcified disease on the proximal and middle AD. The circumflex was quite normal, and the right coronary artery severe lesion at the mid segment. So this is the picture. Yes, you can see it of the proximal and mid AD. You can see better in the lateral view the lesion of just after the takeoff of the septal branch. And here is a lesion of the right coronary artery. So voluntarily for this first case, we didn't choose a complex case. The problem is not to show you if we can do bifurcation with 3 wires. This is not the topic today. The topic is to discuss about the technique of transradial from skin to skin. So it's the reason we have chosen this patient with double vessel disease. So you can see the puncture, the navigation of the guiding, the cannulation of the right of the left ostium. I don't know with which ostium Ferdinand will start. And then we will see the exchange of the catheter from left to right or from right to left. Okay? So Ferdinand and Bruno, you can start the procedure.
Okay, thank you very much. We heard some of your highly scientific discussion on the type of needle, transfixion or no transfixion, or type A to D types in assessment of collaterals. Well, my personal feeling is that we don't have to think more difficult than they are concerning the needle, as long as it's sharp and small and it has an opening. I think you can enter the radial artery, and if you feel a pulsating radial artery, you can use that access site. That's what we are doing in Amsterdam. We do not perform any assessment of collaterals anymore. I don't know if this patient had a previous Allen's test done, Bruno?
Yes, in our cath lab we are doing a systematic Allen test before the case. It's done by the nurse with the oximetry, the pulse, and it was positive for this patient. So we are still continuing to do the Allen test before a radial approach, and if the Allen test is negative at this moment, the nurse signal that to the doctor, to the physician, and we decide if we continue or not by transfemoral or if we move to the femoral.
Okay, but are you moving to femoral if it's a negative Allen's test?
Yeah, sometimes yes. If it's a young patient, for example, it's a worker, sometimes we have some resistance to go to do it if the Allen test is negative.
Okay. Well, it's more than a year ago that we abandoned assessing collaterals, and so far we didn't have any negative comments from referring cardiologists or patients back to our center. We don't have a systematic follow-up of all the patients, but The nurses are deciding what approach to use, and the only thing the nurse does in our center is to feel if a radial artery is present or not. Okay. Having said that, this patient is sleeping, still has a good pulse. Sometimes patient clear and awake has stronger pulsations than patients under anesthesia, but this patient has a good radial artery. I usually assess that by having my fingers over the course of the radial artery. And like Jean Fagedet already said, we shouldn't puncture too distal because then you might access the superficial branch of the radial artery. And this superficial branch is so small it will never allow a sheath in. So you have to puncture 1 centimeter proximal to the styloid process. And but before doing that, we first give some anesthesia.
Yeah.
This xylocaine with a short needle only. This radial artery runs very superficial to the skin, so be careful not to touch the radial artery already with the needle because that can provoke spasm.
During the puncture, if you have any questions, do not hesitate. Do not hesitate. This is the rule of this session. When something is not clear, do not hesitate. Tell us.
Can I have the needle, please? Here, the needle that I will use is a new version made by Terumo. You have these needles available in a kit for 5 and 6 French, maybe 7, I don't know. It's a needle with a sheath. I've heard the comment of Dr. Louvar. I also think a sheath will help. When you have some resistance more proximally, you can make an angio and assess the problem. But as in many other techniques, I don't think it really does matter a lot. What matters is that you use the system that you like most, and something that you use very regularly will be successful in your hands. So there are many different types of needles, and if you properly compare them, I don't think you will find much difference. It just depends on the operator and the operator skills.
Ferdinand, about local anesthesia, have you already tested some local substance instead injection of something under the skin, and do you have any difference for you?
No.
No.
We started in 92 with the radial approach. We gave xylocaine and we are still doing it.
Okay.
But maybe there are more fancy ways. Yeah, I know that the puncture can be painful to the patient. The anesthesia puncture is a sharp feeling. So maybe there are better agents, but I'm not sure about that. Okay. So I will puncture towards my middle finger. I must say that in the meantime, the pulse became a little bit weaker.
So here you are waiting some blood coming back some backflow in the needle.
Can you elevate the table a little bit more?
Yep.
Okay.
John, is it Locha from Dubai? Is there any point in putting some towel below the wrist? I'm on your right. Is there any point in hyperextending the wrist by putting some towel below it?
Yes, well, the patient, I will show you some slide. The patient is on the table with the right arm on the table extension, and there is a pile of gauze under the wrist in order to strengthen the wrist. So this will facilitate first the palpation of the pulse and the puncture.
We find it very convenient.
And the fingers are fixed to the table extension just with the strip.
Jean, there are many opinions because in my opinion it's not good to do that. I prefer a relaxed and not highly supine and not hyperextended. So probably the good way is the way you do it.
No, what I say, but not hyperextended. The patient has to be relaxed. But I think that if you place the wrist like in this position, when your hand is falling like that, naturally, it's easier that to have the hand like this.
Yeah, Jean,
but the patient has to be relaxed on the table.
If I can make a comment, I don't fix the fingers because during the procedure, some patients complain of having, pain in the elbow. So we now don't fix the finger, and as soon as we access, we leave the patient put his hand in good position. But so far, we never had any problem.
We tried that in the past, but if you have any complication during the procedure, could be sometimes a disaster if the patient have the arm like this. But I prefer to have everything fixed. But it's our way of working. Could be discussed.
Doug Fraser, UK.
Yes, go on. Is that a question?
No, it's just a comment really about transfixing the artery and having a sheath. For me, one of the main advantages is that you can puncture the radial artery with a steep angle, and then once you've removed the needle and left the sheath posterior to the radial, when you withdraw it back again, you can go at a very horizontal angle, exactly horizontal with the skin. And so you can have the advantages of puncturing with a steep angle and coming back with an angle that's very much in line with the radial artery to allow you to wire to go in more easily. So for me, that's one of the main advantages.
Other comment concerning the puncture?
We prefer also that the patient has an hyperextension because it's easier for us to have the puncture. Yes, great.
Sorry if I can interrupt the discussion. I had some difficulties in finding the radial artery, and you see maybe you can focus on that I have tried to puncture from distal to proximal. I think that the cannula is in the radial artery now. I will retrieve it a bit. Okay. And now the wire goes in. It wasn't easy, actually.
Yeah. This is the hydrophilic wire of the Terumo, yes?
Yes, it's the hydrophilic wire.
Hydrophilic wire, yeah. Is this wire long enough?
The first comment concerning the puncture, and you can see that Ferdinand has done southern cases and live demonstration. So it's not the stress of the live demonstration. But anyway, you have to take some time. You have to take time. Do not do this very quickly. I tell you, the palpation is very, very important, and the time to do the puncture is very important. And we have to be patient. And the most important is to avoid the hematoma. This is the most important. So if you have some beginning of hematoma, compress your radial for a few minutes and then start again.
As you see, I didn't make a skin incision. With the latest versions of the sheath, the obturator as well as the transition between the obturator and the sheath are tapered. So it's very sharp, and you can enter the skin without making an incision. So at this point, I give the cocktail. This consists of a combination of verapamil, 5 milligram, and nitroglycerin, 200 or 300 microgram. You use 300 here, back home we use 200. Usually it gives a burning sensation to the patient's arm, and that fades away after about 30 seconds. This is the nitro. But it's something you have to prepare your patient for.
Ferdinand, Jean, I know that in some countries verapamil is not available. I remember when I was in India, and they showed me that it was possible also to do it with diltiazem to replace verapamil. And in our institution, we are not using nitrates; we are using only verapamil. And we are still injecting heparin in the radial. I know that this is a mistake because this is acidic and this is painful for the patient, and maybe it can induce also a spasm. So we have many types of cocktails.
Is better. You can use diltiazem instead of verapamil, and diltiazem doesn't give that burning feeling. Yves?
Sorry, I didn't understand your question.
Oh, the question was if you feel that with diltiazem there was less pain for the patient compared to verapamil?
I don't remember that, but they were using systematically diltiazem, and we had no more spasm.
Concerning the pain.
Okay.
And Fina, what are you using?
Ferdinand?
Yes?
Yes. Would you start by the left or the right?
Well, this is the latest version of the Kidney Guide, which is a multi-purpose guide, and it has just been introduced a week. I used a couple back home. It will cannulate left and right, although I must say I've always very much difficulties here with the Kidney Guide because the patient cannot breathe in and out, and it's a very active cooperation that we need from the patient. So we'll see.
We have chosen this case to show the exchange of the catheter. So you can start the left with your catheter, and then maybe do the right with another one, just to see the exchange.
We'll see.
Okay.
I think there is some discussion on the severity of the disease in the LAD. So we will approach the right coronary artery first. Can you flush? And that's a discrete lesion. It's a bit tortuous vessel. Has some calcifications, but I think it's very good to stent directly. And then we'll go to the left coronary artery. And when reviewing the films, we're having doubt about the severity of the ostium of the LAD, of the left main. The patient certainly has left main disease. And the lesion proximal LAD and mid LAD are maybe not that severe. There was some bridging as well. But let us concentrate on the right coronary artery first. Okay, can we go to LAO, please?
Yeah. Le zéro est bon? Okay.
There is one point about that we didn't talk about was the length of the introducer, and actually we are tending to use shorter and shorter sheath because we think with that we induce less trauma to the artery. What is your position on that, Ferdinand?
Yeah, I agree with you. We started long ago with long sheath because of the advantage of, we thought that with a long sheath the patient would not develop spasm because the movements of the guide catheter are not noticed by the patient with a long sheath. But on occasion, if the patient develops spasm, a long sheath is very difficult to take out. And in the course of time, here the hydrophilic sheaths were developed. We had them in different lengths as well, and we were using cocktails. And with the combination of a spasmolytic agent and the hydrophilic sheath, I think spasm is a very rare event. And that's why we have abandoned the long sheath, and we are using 10 to 13 centimeter sheath, depending on the specifications of the manufacturer.
I think that we move now to the cannulation of the right.
Okay. Well, the catheter is in the left coronary sinus. I just lift the tip a little bit over the aortic valve, and then turn it clockwise to the right. And then go down here.
La fluoroscopie, DG Vision.
Yeah. Okay. Good. You still have good pressure or some damping?
No, some damping of the pressure because it's a small right.
Okay. We'll make film?
Yeah.
Okay. Good. Well, there's a mid-RCA lesion. There's also distal disease, but we had not the intention to treat that. It's maybe not so severe. There's also some stenosis at the distal bifurcation. There are small vessels there. So we only want to focus on the stenosis in the second segment. Maybe we need an RAO.
Okay. With your specific guiding catheter, you can cannulate every type of anatomy of the right, or for example, a Shepherd crook, or is it? Do you change sometime for other?
Well, I'm so used to use this catheter that it wouldn't be fair to ask me this question because I can really use it in almost all occasions, and sometimes I have to change. But I know also from our fellows and people starting with this catheter that it's not easy to start with, and so also this curve has a learning curve. So actually, you should ask other operators to.
But while Ferdinand is working, have you any question about the guiding catheter concerning the right coronary artery? I suppose that in the room we have some problems, or maybe we use all the catheters. Any comment concerning the guiding? Ashok, what's your guiding? You are in the first row, so.
We have a Cobra multi-purpose catheter using for left and right. Do you use that? A Cobra catheter which is for left and right.
The Cobra?
Yeah.
No, I heard about that, but I never use it. Any experience with the panel? In the room?
Not.
Somebody is working with the Cobra catheter?
We have used in our...
Can you explain the shape and the interest to the...
The curve it's more like an JL4 with the extra second curve, so that the second curve allows it to use it for the left diagnostic, and the first primary curve sits for the right corner. Only thing gets sucked into the right corner more often inside. That's the problem. Otherwise, it's a very good catheter. In fact, we do left ventral angiogram also with that, LV angiogram. With single catheter, we finish off all the three diagnostic with the Cobra catheter.
And there's different size, different shape?
No, unfortunately, there's no different size yet available.
Okay, there's a unique size.
Same size.
Okay. Other comment about the guiding catheter? Somebody is using Amplats for the right? Nobody in the room? Yves Louvois is the 100% Amplats for the right, left, and
John, one can use a LCA catheter with a short curve, 3.5, which can use right and left both.
small here because the guiding.
The left 3.5 for both left and right can be used the same. Dr. Luer, you don't give heparin through the sheath, right? That's what you're saying. Heparin should not be given through the sheath.
Normally we use the 3.5 for the Judkins left. Normally, when we have a normal aorta size. And for the right coronary artery, if we use a Judkins, we use a GR4.
Yeah, I used in one patient because I had lesion in the left circumflex, and I used the same catheter for the Judkins 3.5 LCA curve for left coronary artery, then rotated, and it gives a very good backup support for the right coronary artery.
Okay, very interesting. Other comment?
They say that when you do from the left radial, JL4 is better, and right radial JL 3.5 is better. Any experience?
With the?
If you do the left radial, it is JL4.
Yes.
JL4. Right radial JL 3.5 because the secondary curve from the innominate to subclavian is different.
Maury, you are working with the Judkins?
No, I don't like the Judkins for perform PCIs. One thing is in the diagnostic. When the residents, the doctor residents learns, we prefer the Judkins. When my colleagues and me works, we prefer a multi-purpose catheter like a radial by Terumo or the radial by Boston. They are very easy to use. But when we perform the PTCA, we prefer the extra support catheter, so an EBU, an XV for the left coronary artery. Always, in almost all the patients, we use this. And for the right coronary artery, we have some problems, but the most used in our hospital is the ACR from Medtronic also. And they have a good support.
This is a slide showing the Quebec Hospital institution, and you can comment, Gerard.
Yeah, as you see for angioplasty as guide, I use Barbo in 99% of the right and extra backup kind of curve in LED and Circ in 99%. And so my life is very, very easy. And two shapes, that's it. For angiography, usually in 4 French I use the multi-purpose. In the 5 French I use the Barbo curve to do the angiography, and it includes the LV angiogram that I do manually. AL2, JR4, JL35 and pigtails are mostly my colleagues also span, but some people use one catheter, but I prefer to use one catheter to do all the angiogram and LV and right. But for angioplasty, I prefer to choose between two. But it's very simple, as you see. The most important point is that use what you feel comfortable with and stick with it, and you will become very good with it because you know how it behaves, basically. So that's my...
Bruno, what are we doing now?
Can we interrupt the discussion for a moment? Yes, because we need to continue here.
Continue to work during the discussion. Do not stop, eh?
Yeah, but I want to make some comments here. As you, maybe you didn't see the pressure curves, but we have some damping. You can easily manipulate the guide just by pushing on the wire. That's one. By pushing the wire, the catheter comes out of the ostium. Then you can increase support by advancing the catheter deeper over the wire while holding the wire. So you can actually play with the catheter and modify the amount of backup that you need. This is a vessel of moderate tortuosity. The lesion is of moderate severity, so I don't expect too much problems when crossing with the stent here.
Oui.
And so I don't need backup because the catheter is not in the ostium now. Here, you see? And only for a better look, you can advance the catheter again. Yeah, contrast.
Do you recommend extra support wires for the right coronary artery?
It was in the middle. Okay. Yeah. Est-ce qu'on peut revenir à... à la lésion. Philippe, l'image de référence.
Oh yeah, it's lower.
Yeah. C'est bon, merci. Okay.
I may answer for the guide wire. Personally, I think that the guiding catheter is more active from the radial. You have to work more actively and don't feel that you need the passive backup. So then I think that the wire doesn't make any difference. I can use any kind of wire, it will work, as long as I can play my catheter to the active role I need.
What do you think about the very big marginal branch? You don't protect it?
Jean, the problem of backup support was raised during at the beginning of this session. So I think you have to understand you have to have two kinds of support. As a passive support from the ostium with very high support catheter. Personally, I'm using near always an Amplats for the circumflex and sometimes also for the right. And the second option is to use an active support that is a kind of deep intubation. And in some situations, it can be very interesting to use a 5 French. Not always, but for example, when I'm doing a mammary graft, I'm near always using a 5 French. So you have those two options. So it's very important to choose your catheter. If you don't need a support, you think you don't need a support, you can use a JR and GL for the right and the left. Certainly for the circ, you have to take care to the angulations. And if you need a really active support, a passive support, but at the ostium, you can use the Amplats for the circumflex for the right, and why not for the LAD. And maybe other very aggressive catheters or deep intubated catheters, like for example, for the right, the Ikari from Terumo is also a very interesting catheter for active support.
Now we're going to the, maybe you've seen the result on the right coronary artery. We turn the catheter clockwise into the left coronary sinus. And then I can push the catheter up a bit until we see the ostium. Yeah, contrast. Yeah, okay, and then I can pull it back. Okay, let's make a spider first for the left main.
The tip of your catheter is inside the left main. So what is the maneuver now to coaxialize?
Yeah, for angiography, I don't need to coaxialize it, but later with the wire in, you can coaxialize the catheter.
We have the problem with the satellite, because normally the satellite will be stopped in 1 or 2 minutes. So I think we have to finish show you what you have to do, and what you can do is to record all the end of the procedure. Okay?
Okay, we will.
So Ferdinand, you try to coaxialize with a wire inside, or you try to do it now?
I can just pull on the guide here. I pull on the guide, and now it's coaxializing. You see?
That's good. Yeah.
Oh well, it's out of the.
So there is a good news for the satellite. You can continue for 5 to 10 minutes.
Okay, perfect, because now we have the problem of the LAD lesion.
We have decided to do an IFUS on the LAD in left main. Okay. So I use the same wire. The wire that I'm using is from Terumo, the run-through. It's a nitinol wire.
Usually in your cath lab, what type of wire are you using as a first choice for this type of case, standard case? It's a BMW type wire?
Standard case is BMW or lookalikes. And for the cases, the tortuous vessels, calcified vessels, where you need more support, I use the Choice extra support catheter, a wire. Well,
Is there any questions about guiding catheters for left or right?
Is it in your experience, Dr. Leward, that when you maneuver the guiding catheter by torquing it, the spasm again reactivates. If you hold the sheath and then torque it, is it less? Is it true, or what is it? If you torque the catheter, there is more chance of getting spasm again after 5-10 minutes after puncture.
I think it's true. The torquing, too much torquing is a factor of spasm, certainly. So this is the reason why experienced operators see near disappearance of spasm. And this is the reason why young operators in radial approach have more spasm. They are torquing a lot. They are doing a lot of maneuver to catheterize the ostium. And this can lead to a spasm, to a radial spasm, certainly.
If you hold the sheath, the hub of the sheath, is it less? If you fix the sheath, then it doesn't help it in a long sheath.
No.
Excuse me. You can explain the mother and child technique of the guiding caster?
I'm going to speak about that. You may ask a question to Dr. Saito later, because he is using mother and child catheter, but I don't think we have it in Europe.
That we will show you the.
Okay, so maybe we can review now the image of the IVUS. Okay. Okay, tu fais oui, il faut que tu valides oui.
We are in segment 7 of the LAD.
Oui. Okay.
At the diagnostic angel, there was bridging visible in that particular segment.
It's an automatic pullback at 0.5 millimeter per second. And we are now in the middle AD. We are going back. We see some calcified plaque here. Between 0 and 3 o'clock here, it seems a very severe lesion. What do you think, Ferdinand? It's a very calcified and severe lesion. I think that for me here, there is no doubt that it requires treatment.
This lesion is proximal to the septal branch?
Let's see. See, just at the level of the septal branch.
Okay, we proceed with IVUS, please.
Still... very tight lesion, huh? We have an arc of calcium between 3 and 9 o'clock.
Yeah.
And we're now approaching of the left main.
Bruno and Ferdinand, would you predilate this lesion?
I would try first without predilating.
And Ferdinand,
personally, I will do a predilatation because it's a calcified lesion and we see a lot of arc of calcium, but I know that Ferdinand is most experienced than me, that is more confident for direct stenting. Okay, and now we approach him here.
There are two risks in direct stenting. First, not to go through. This is not a problem. You remove the stent and predilate. And the second one is that you cannot open the stent. So this has to be taken in consideration too.
Okay, now we are in the aorta. We don't see any severe lesion at the level of the ostium. So I think that we can move now to the treatment of the proximal LAD lesion. Stop. Okay, we can remove the...
On the other hand, it's a long lesion, and predilatation in a calcified long lesion might also induce a dissection, which might be...
Bruno, the lesion starts from the very proximal, from the LAD to the septal branch.
Yes. Can we review the film, please?
Yeah.
Okay. Can we review the film?
So you plan to place a long stent?
Remontrer l'image de ref.
Yeah, a long 3-0.
Okay.
Okay. Maybe we will do a LAO caudal to see the origin of the LAD, no? What do you think, Ferdinand?
Yeah, it's okay.
Because here we don't see perfectly the origin, the ostium of the LAD. And it could be a matter of discussion where we have to stop the stenting.
What about the left main lesion? It's not been assessed.
Okay.
There's a question about the left main lesion.
Yeah, we saw the IVUS image and it doesn't seem to be very severe. We don't see any very severe narrowing at the level of the ostium. We can review maybe after the IVUS image, but it will take maybe a long time. So as we have only 5 minutes to finish the case, maybe we can move on the LAD, and if we have time to review after the ostium of the left main.
So now I'm increasing backup by advancing the wire deep, and I have I push on the catheter, so I think the whole system gives enough support. And let's take a long 3-0 Texas, about
24, 28?
28.
3028 Texas. But we have to know that it's a diabetic patient with a diffuse disease, and we see that even in the mid-LAD that there was also some disease down to the more critical lesion.
Yes, absolutely.
Any question concerning the guiding?
So what we plan to do is now to treat the proximal LAD lesion, to inject some nitrate, and to review carefully the ostium of the left main and see if we will require some additional treatment.
I think in this case I would have used an Amplatz or an extra backup.
Is to better see the ostium of the left main?
DG, la fluoroscopie, s'il vous plaît.
Or to have a better support.
Yeah, you saw the trick maybe with the catheter. You can actually deform the catheter to an Amplatz-like shape. Let's make an injection here to see where we are. I'm using the wrong pedal. Okay. It's too proximal.
Yeah.
So again, I advance the catheter.
You have to check in caudal, huh?
There was a lot of calcium by IBUS, and it's difficult to advance and direct stent in this situation, I think.
Yeah. I think the position is quite good. Let's see in LAO caudal.
LAO caudal?
Yeah.
Like this? Or more?
More LAO, maybe. Yeah.
But it's important to check in the LAO caudal. So when you use a transradial approach and the right radial approach, we can check the coronary tree in all the different views and projections, except the LAO. We have from LAO 60 degrees to 50 degree to 90 degree lateral. We have this zone totally blind. Because of the arm and table extension. So if you want to work in LAO, we have to work between 0 LAO and 40 caudal or cranial. And if you need the lateral, you have to go over 90 degrees, work in 95, between 90 and 100 degrees lateral. And this is absolutely perfect.
Yeah. It's okay?
Yeah.
With this,
there's some foreshortening. I will show the stent expansion in RAO.
So you have, I don't want to make the pressure on you, but you have now less than 1 minute. So just the time to deliver the stent and show us the result. And then Yves Louvois will give a short presentation on virtual reality, because the second case will start at 3:30.
The stent was well expanded angiographically despite the calcifications. So we can check that later by IVUS if you want, but that will be done offline.
IVUS and maybe if we have time, you can give you the images during the second case.
Okay. Can we go to LAO cranial?
That's good result.
cranial.
Cranial?
Yeah.
Iliocranial.
Yeah.
Excuse me. Okay.
Okay. But this is a very nice result.
Well,
so,
we can
Ferdinand,
stop
thank
here.
you.
Yeah.
We leave you. What you can
Okay.
do later is to go with Bruno and to work with Shigeru Saito in the other room. Okay? So
Okay,
see you in
okay.
10 minutes in the other room. I think now it's time to